electronic cards where you can register all the sessions. This is very useful, and be aware of also photosensitizing medications. The contraindications for PUVA and narrowband, you see the absolute gene defects lupus for PUVA pregnancy or lactation, and relative contraindications for both photochemotherapy and phototherapy are all the skin type 1, dysplastic melanocytic nevi, skin cancer, etc. And for PUVA, of course, prior exposure to the high cumulative UVA dose and therapy with ionizing radiation or liver disease. So, the last part of the present, the last topic is targeted phototherapy. Targeted phototherapy is phototherapy that essentially avoids exposure of healthy skin, unnecessary radiation on healthy skin. It is very useful in selected cases and in limited cases of the disease. As you will see in the second presentation, it can usefully be used also in vitiligo. We have different light sources. The most well-known sources are the excimer laser that has been described at first, the excimer light. And then it's interesting to know that we have non-laser sources that are cheaper, so interesting for the office practice probably. And they have the same effect, the radiation is targeted, but the wavelength is different. So they may be less effective as compared to excimer light and excimer laser. What does excimer technology mean? We have, the name excimer is an acronym for excited dimer. We have different gases, excimer lasers and lamps use different reactive gases, such as chlorine and fluorine. And when electrically stimulated, there is a pseudo-molecule, a dimer is produced, and the dimer is excited when lased and produce light in the ultraviolet range. You can see, based on the different gas, the one that is interesting for dermatology is xenon chloride, where the emission is in the 308 nanometers peak. So that's the narrowband UVB for excellence. Excimer laser differs from the lamp because it is monochromatic, it is coherent and collimated. The lamp is, has a sealed transparent tube filled with the gas, the xenon chloride. There is the discharge that produces excited dimers, and then you have a beam that is not focused and not coherent. This is the main difference. But the wavelength is always 308 nanometers. As you can see in this study in psoriasis, it has been demonstrated that the wavelengths of 308 may be more efficient in inducing T-cell apoptosis as compared to the 311 nanometers wavelengths. Mainly, these are the two mainly used devices in the United States that have been registered for therapy with excimer laser. The irradiance is very high compared to the narrowband UVB ramp and cubicle, and the laser can be used in a pulse mode or in a continuous mode. Here you have some examples, models of excimer lamps on the other side, and here are summarized the main differences between the laser and the lamp. So, current, let's say in summary that the excimer laser is more time consuming, has a more powerful output, and is indicated for smaller agents. The excimer lamp perhaps is more suitable for the treatment of larger areas. What about the protocol? In psoriasis, we start usually with 3- or 4-fold EMED, determined on healthy skin, and we can increase 30–40% of every treatment. Nevertheless, very good results have been obtained with a very aggressive protocol exposing the lesions to 8/16 times the MED. In this case, we have clearing only after 2 or 3 sessions. Here is one of our patients on the left side treated with the laser. You see the results of only 2 exposures. 4 weeks of treatment, 8 treatments with the excimer laser, nearly complete clearing on the elbows. 3 weeks with the excimer lamp, you see very good results on the elbows. These are difficult areas. And with the excimer laser in 4 weeks, you have complete clearing. With the excimer lamp, always on the elbows, very nice results. What about the side effects of the excimer laser? Of course, you have to be very careful. You can have blistering, erythema. This is a case of vitiligo, of course, and you can have important hyperpigmentation. You should warn the patient. You have the possibility to use also different sources that don't have the 308 beam and are represented by filtered high-pressure mercury arc lamps. So this is very cheap as compared to the laser. The results are quite good, but not as good as with the laser. At last, combined phototherapy can help to reduce the side effects of phototherapy, to shorten the duration of the treatment and have less side effects. So we have topical drugs, topical products that can be used to hydrate, keratolytics for instance, and products that have synergic effects like steroids, ditronol, and vitamin D analogs, and also tazarotene has been used. This is very useful to improve the outcome and reduce the duration of treatment. About systemic treatments, the most well-known is the association between acitretin and buva, where it has been clearly demonstrated that the results are much better than buva alone. So this is a mainstay in very severe psoriasis. And also acitretin and narrowband UVB works very well. We use it frequently in difficult cases with very good results. And at last it has to be kept in mind that acitretin and retinoids have a protecting effect on carcinogenesis in skin exposed to UV radiation. What about the retinoids? Systemic combination with biologics has been used with different results. The new biologics are less immunosuppressive, so it could be attempted the possibility to have a combined treatment, and this could represent a positive side. On the other hand, the very high cost of the biologics, and this therapy should not be recommended for standard use. And the benefits have to be determined. This is one of the last publications where you see that 311 UVB accelerates the response to patients treated with adalimumab. But it's only a report, and we don't have data on large studies. What about the cost? As you can see, UVB and buva have a very, very lower cost. Just the methotrexate has a lower cost than UVB and buva as compared to the new therapies. So it's needless to say that phototherapy has a very interesting cost as compared to the new treatments with biologics. Home phototherapy can be used, and it's a good solution in some cases. It has been demonstrated by the authors in the Netherlands that it is very useful in some cases. And so, what are the take-home messages? Phototherapy of psoriasis is relatively cost-effective. Phototherapy may be combined with topical agents. More than 200 buva therapy should be avoided. The mode of action of phototherapy is the inhibition of keratinocyte and the immunomodulation. Even in the era of biologics, phototherapy remains an important therapeutic modality for psoriasis and other dermatoses, and phototherapy demonstrates efficacy rates among the highest of all available therapies for psoriasis, and it's one of the least costly treatments. This is very important. Thank you very much for your attention.